Hello everyone, welcome to another one of our radiology lectures with me, Dr. Mark Spriggs. Tonight we are going to be discussing crystal deposition induced arthropathies. I think as manual therapists it's important for us, so chiropractors, osteopaths and physiotherapists, I think it's important that we understand how to differentiate these conditions from your typical degenerative joint disease, arthritic changes, because ultimately whilst the crystal deposition arthropathies will cause an accelerated degenerative joint disease, because ultimately the crystals are where they get deposited within the joint itself, they will cause inflammation and erosion of the joint tissues, so the patients will present with obviously joint pain, swelling and loss of range of motion. It's important for us to know that these things are going on and how to recognize it on an x-ray, because ultimately your plan of management is going to be completely different to a patient for a patient who's got a crystal-induced arthropathy in comparison to a patient who's got just simply a degenerative joint disease. And these things can be missed sometimes when a patient's had it clinically, they've had imaging elsewhere, so they might have gone to hospital, or they might have also had it done in another local clinic, and these things can be missed. So it's important for us to be able to recognise them and know where to go from there. I'm going to try my best as well, guys, to try and make my voice a little bit more interesting, a little bit less monotonal. I know my last video was probably great for putting you guys to sleep, but ultimately, you know, I was filming it late one evening, and that's my story, and I'm sticking to it. So there's three main types of inflammatory arthropathy or crystal-induced arthropathy we're going to go through this evening. The first is gout. Then it's calcium pyrophosphate dihydrate crystal deposition disease, or CPPD, and then hydroxyapatite deposition disease, or HADD. All fun acronyms for us to really remember. So the first one's gout. Reason why we're going through gout is because it is by far and away the most common of these conditions, especially in sort of the Western world in particular. It is obviously a crystal deposition arthropathy, so it's a chronic inflammatory arthropathy. It's caused by uric acid crystals being deposited in the joint, which causes inflammatory reactions, soft tissue swelling, joint pain, loss of joint space, and eventually will lead to joint erosions. Typically, you'll have a male who's over the age of 40. The male to female ratio is 20:1 for men, so this is far more common in men than it is in you ladies. It's usually the lower extremities, most commonly the big toe, but it can also include the ankle and knee. It can progress to polyarticular as well, so whilst it's common in the big toe, it can affect the obviously local other tissues, so it will cause deposition in other joints of the foot, or obviously it will start in the big toe and it will progress to ankle and knee. Genetic factors associated with hyperemia, with a clear, or according to these guys, a very strong familial history is in play with gout, and it's associated with chronic nephropathy and renal disease, causing impairment of the kidneys to be able to filter out uric acid, causing the hyperemia in the first place. And this is all found in this paper down here, the Global Epidemiology of Gout, Prevalence, Incidence and Risk Factors. So have a download of that one if you want to have a good read through this in a bit more detail. So here it is on an x-ray. The reason why I start with this x-ray is because the findings are pretty subtle. You know, for most of us, apart from the fact that there's obviously a bit of metal up here, and we can obviously see the popliteal artery. We've got some atherosclerosis going on in the popliteal artery and at the back, and a little bit more in the plantar fascia down here as well. We've obviously got a couple of loose bodies back here as well, but otherwise this looks pretty innocuous. For the more astute clinicians out there, you'll be able to see that there's quite a lot of soft tissue swelling, especially around where you would expect the joints of the big toe to start. So this is your sort of giveaway with this particular case. The reason why I'm using these cases as well is because a lot of people are fooled into thinking that x-rays aren't all that great for visualizing soft tissue, but ultimately if you've got a decent machine, you've got its you've got your collimation down, you've got your exposure factors right, you will see a lot of soft tissue involvement X-rays are by far and away the easiest way to diagnose gout in particular, and obviously joint arthropathies in any place. So there's your giveaway sign that this is going to be involving this side of the foot. And here's the AP view, and we can clearly see again that soft tissue swelling as it extends outwards away from the joint of the big toe. Here we've obviously got some subchondral cysts forming as well, so that's pretty obvious. We've got some joint erosions going on, and it's the same in the little toe over here as well, where we've got quite large joint erosions. You've got clearly subluxation of the little toe, and again lots of soft tissue swelling. We've also got subluxation going on here of the second toe, just here as well. So not a particularly good looking foot just there. This is going to obviously be incredibly painful with all this soft tissue swelling. And here's a really extreme case of how the X-rays can be very, very helpful for soft tissue differentiation. I know the image is a bit blurry. I got this off of Radiopedia, courtesy of Dr. Shetty. But yeah, this is an enormous soft tissue swelling. Just here you can see just how far out the joint tissues go, and there's quite a lot of erosion as well around the big toe. So again, X-ray is very, very helpful for making the diagnosis here. Ultimately for this patient as well, obviously you struggle to get a shoe on with a joint that big. So very, very important for this particular patient. Next, we're going to move on to CPPD, calcium pyrophosphate dihydrate crystal deposition disease, also known as CPPD or pseudo gout, which is a bit of a giveaway, isn't it? So the pathology, basically, pyrophosphate binds to calcium, and it leads to CPPD deposition on the cartilage and within the synovium of the involved joints. It is associated with an overactivity of the enzymes that break down triphosphates in the patients with CPPD. That's quite commonly seen. You'll obviously have gout-like symptoms, obviously the clue's in the name if it's called pseudo-gout. So you'll have gout-like symptoms in the presence of crystals, so obviously joint inflammation, erosions, loss of range of motion, joint swelling, pain. Chondral calcinosis, which is obviously when the calcium gets laid down on the cartilage, may precipitate premature degenerative joint disease. In the spine, it will cause early or accelerated degenerative changes, especially of the lumbar spine, and in the peripheral joints, it will cause chronic joint inflammation, which will eventually lead to erosion, which can be severe enough to simulate neuropathic joint disease, which is what we went through in the last video. So quick recap on that one. It's only a short video if you want to go through that. Clinically, so lab findings are basically, they include aspiration of crystals from the synovium of the involved joint, and it can sometimes be the only definitive lab finding. The crystals will be deposited in hyaline and fibrous cartilage adjacent to chondrocytes, usually an intimate layer, but never on the surface of the bone itself. You'll also find it in capsular ligaments and in tendons. Screening for these patients with CPPD includes collimated projections of the wrist, knee and pubic symphysis or symphysis pubis, with nearly 100% of these cases will have involvement of all three areas. The calcification or chondrocalcinosis is the most common and characteristic form of the calcification, involving either hyaline or fibrocartilage. The hyaline cartilage, you will see a thin linear parallel line to the articular cortex, and that's usually found in the wrist, knee, elbow, hip and shoulder. Whereas with fibrocartilage, you'll see a thick, irregular or shaggy appearance with poorly defined margins. This is usually found within the meniscus, triangular fibrocartilage of the wrist, symphysis pubis, and the annular fibers of the intervertebral discs of the spine. Arthropathy is most common when the calcification is visible on the X-ray. So once the calcium, obviously you can see the mechanism of injury, can't you? Where the calcification starts, or where the calcium gets laid down, ultimately that means you've got a layer of cartilage that's rubbing against a roughened area of calcium, which will lead to obviously micro trauma within the joints, which will obviously cause tissues to bleed, which will cause obviously the inflammatory pathways to be triggered, causing the swelling and obviously pain. And the longer that goes on for, the more repetitive injury you'll get, and therefore obviously the worse off the patient's going to be in terms of function and prognosis. Clinically, it's equal in men and women. Onset is typically is usually over the age of 30, with a peak age of 60. Obviously, most commonly presents with similar symptoms to degenerative joint disease. So if you've got a patient over the age of 50 with degenerative joint disease symptoms, it doesn't necessarily mean it is simply DJD, especially with CPPD happening in, or most commonly occurring, obviously in the knees, wrists, hands, ankles, hips, elbows, all the typical joints that you would expect with simply degenerative joint disease. So I think it's important that we can recognise the difference. This is also associated with diabetes, degenerative joint disease, gout, Haemochromatosis, Wilson's disease, and neuropathy. Okay, so obviously these patients, well, obviously diabetics, things like this, you're looking at sort of middle age and upper in these patients. Just to go through them in case, obviously in case you need a bit of revision, or if you didn't already know. Haemochromatosis is a hereditary condition resulting in a gradual build-up of iron in the blood and within the organs of the patient. Obviously, once it builds up in the liver, it will lead to cirrhosis. In the pancreas, it will lead to diabetes. In the skin, it leads to a bronzing of the skin, which is why this is commonly called bronze diabetes. And in the heart, it will cause cardiomyopathy. The triad is obviously all of them. So cirrhosis, diabetes, bronze skin, which is again why it's called bronze diabetes. It's also associated with hepatomegaly, splenomegaly, weakness and lethargy, chronic abdominal pain, loss of libido and impotence eventually. Obviously arthralgia as well, I skip that one, so obviously joint pain. Wilson's disease, again, in case you didn't know or if you needed a bit of revision. Obviously Wilson's disease is a hereditary condition causing the buildup of calcium to accumulate in the patient's organs. It is also known as hepatolenticular degeneration. Obviously, it will build up in the kidneys, it will build up in the brain as well, which will include in the basal ganglia, which will lead to chronic neurological symptoms such as tremors, chorea, personality changes, depression. That's supposed to say psychosis. I'm very sorry, guys. That is supposed to say psychosis. I don't know what psycholysis is, but anyway, ignore that. That's supposed to say psychosis. In the liver, it will cause cirrhosis, and you'll also get in the cornea where you get the usual Kaiser-Fleischer rings, where you'll get usually a gold appearance around the outside of the cornea when you look into the patient's eyes. The knee is by far and away the most commonly affected joint. Chondrocalcinosis of hyaline and menisci. Medially, it will lead to femoral tibial issues, patellofemoral, or it can be lateral as well, and you'll also get superimposed degenerative changes as well. So here is a patient's knee, and you can see it here within the joint surface all the way along, medially and laterally. As you can see, it's that more sort of, so in this particular case, it's obviously juxta-articular. It's a linear appearance of roughened and very thick edge, quite shaggy end with ill-defined borders. So this is obviously most likely going to be within the meniscus. You've also got some loose bodies back here, quite large joint mice back here, and you can see it posteriorly and obviously leading anteriorly just here as well. In this particular patient, there's very little evidence of any sort of joint degenerative disease in particular. So there's, you could argue that there's a little bone spur occurring on the medial aspect of the tibial plateau, but otherwise this looks like quite a healthy looking joint, other than the obviously the calcium build-up within the joint tissue itself. This is obviously a much more severe case where we've got it all over the place. Again, very thick, shaggy appearance in the lateral aspect of this patient's knee. We've got bone spurs occurring medially and laterally. It's within the collateral ligaments as well. You can see it ascending up into obviously the tendon of the patella. We've got quite a large patella subluxation here as well. Obviously the patella should be somewhere in the sort of medial, in the middle aspect of the distal femur, but obviously here it's translated over quite far to the lateral aspect of the femur. So we've obviously got a subluxation just here, it's really leading to maltracking. And this is the same patient's knee from the side as well. So again, you can see a lot of it posteriorly. Anteriorly, we've got some early degenerative changes occurring on the patella, and you can really see it sort of spilling over the posterior aspect of the tibial plateau with some erosions and some bone spurring occurring. So again, this is not a good looking knee, and it's no wonder the patient's got pain. This one is a little bit more subtle in its appearance, because when you first glance, it looks as though we've got quite large bone spurs occurring in the medial aspect bilaterally, a little bit in the lateral aspect of the tibial plateau again just here. So you've got quite a uniform loss of joint space bilaterally as well. So it's not really fitting your typical degenerative joint disease, where you've got that's the real typical presentation of usually the medial aspect of the joint will go first in terms of degenerative joint disease. So it's usually not symmetrical both sides. So that's a bit of a giveaway that there's more of an underlying problem going on with within these knees. And if you look really closely within the joint lines, both sides, you can see that quite sort of thick layer of calcium that's been laid down within the joints, both sides. It's easier to see on the right side than it is on the left, but ultimately if the patient's got it one side, we're going to have obviously this is a polyarticular case here, and this is the same patient with the lateral projections of both the left and right knees. And again, first glance, you could easily be mistaken for degenerative joint disease. We've got some loose bodies in here in the left knee. We've got quite significant degenerative changes occurring in the posterior aspect of the patella. But ultimately, once you look a little bit closer, you can really see that calcium being laid down on the cartilage, especially of the distal femur, bilaterally. So there's your giveaway that this is a calcium deposition disorder rather than just your typical case of degenerative joint disease. In the wrist, commonly seen is calcification of the triangular fibrocartilage. Hyaline cartilage can be affected anywhere. It's got an affinity for the radiocarpal joint in particular, with decreased joint space between the radius and the scaphoid, and you'll also have the superimposition of degenerative joint disease as well. You'll also get disruption of the ligaments between the scaphoid and lunate, leading to what's called the Terry-Thomas sign, or the step ladder appearance as well. So I'll show an example of that in a moment. So ignoring the fact that obviously there's great big yellow arrows telling you what's going on, just here, on the grand scheme of things, it looks quite subtle on this patient, but if you look really closely, you can see again distal radius. You can really see that there's some calcium, a very thin layer of calcium being deposited here between the lunate and the distal radius in particular, heading towards the syndesmosis between the radius and ulna. So that should give away signs just there. In this patient as well, there's very little else going on. There's no signs of any real sort of swelling. The soft tissues don't appear to have too much swelling going on, as well as there's no joint effusion, and there's no superimposed degenerative changes either. There's no bone spurring, there's no subchondral cysts or sclerosis going on. So it looks as though it's very, very subtle sign on the distal radius. Here's another one as well, where we've got that typical destruction of the joint space between the scaphoid and the distal radius, which is your giveaway. And then here's the calcium being deposited over sort of between the distal radius and the lunate and over towards the ulnar surface as well. So this is advanced degenerative changes going on in here between the scaphoid and the radius. You've also got quite a large subchondral cyst. So again, this would be very easily, at first glance, you could easily diagnose this as degenerative joint disease, but here's a giveaway that this is actually a deposition arthropathy. And here's a nice demonstration of what's called the Terry-Thomas sign, where we've got a gap, quite a large gap between the scaphoid and the lunate, which indicates that there is disruption of the ligaments between these two joints, or between these two bones just here. On this particular image, you can't really see much in the way of sort of calcium being deposited. I could argue that there's a little bit here next to where the arrow is sitting, but otherwise, obviously the image contrast is high on this one, so soft tissues are very much going to be invisible when you've got an image that looks with a high contrast level like this. So it's not a good quality image. So obviously it obliterates the soft tissue involvement there. So there probably is a bit more calcium to be seen, but because it's going to be such a thin layer of calcium, it might well be that this is the contrast has just removed it from the image, so you're not going to be able to see it. Again, ignoring the helpful arrow, here is obviously calcium being deposited on the cartilage around the head of the humerus in the glenohumeral joint just here as well, so it's quite a subtle sign, easily missed. Again, on some x-rays, if you've got a patient with persistent shoulder pain, you take an image and you can't see that there's much in the way of degenerative changes. So in this particular case, there's not much in the way of erosion. There's no subchondral sclerosis. Argue a little bit, it's got subchondral sclerosis just there, but it's quite subtle, especially with an image with this higher level of contrast as well. There's no subchondral cysts. There's no real obvious sort of loss of joint space. So again, very could easily be missed. But here's your subtle sign. There's that very thin linear layer of calcium being deposited that's sort of superimposed over the top of the joint. So it's not within the bone itself, it's going to be along the cartilage. In the symphysis pubis, you'll get a very obvious vertical linear calcification of the joint's fibrocartilage with associated degenerative changes as well. Symphysis pubis is not the typical joint site for arthritic changes, so it's quite it's going to be a bit of a giveaway if you're starting to see signs of degenerative joint disease happening in the symphysis pubis, because it's not the most common site for that to occur. And again, ignoring the great big arrow that gives the game away, here you've got that vertical layer of quite roughened appearance, almost like a shaggy appearance of calcium being deposited within the fibrocartilage of the symphysis pubis. So obviously this will also cause joint pain, swelling. You've got some subchondral sclerosis on this particular image as well, so it's looking quite bright, quite dense around here. So again, there's your giveaway that it's not simply arthritis, this is calcium deposition. So there's your CPPD. Next we'll move on to the hydroxyapatite deposition disease, also known as HADD, calcific tendinitis, peritendinitis. you just don't see this written down anymore. It's usually calcifying tendinitis or calcific tendinopathy. Clinically, again, equal distribution between men and women. Ages between 70 and 40 is quite common. Most common in one joint, but can involve multiple, so it can be polyarticular. Most common site is the shoulder, followed by the elbow, wrist, shoulders, hips, knee, ankle, foot, cervical and lumbar spine regions as well. You will also get, again, patients coming to you with painful tenderness, localized swelling and decreased range of motion of the joint. There are 0 lab findings for HADD, and diagnosis is best made with radiographs with basically findings of calcium being laid down in the tendon. Radiographic features, again, most commonly affects the tendons, but it can also affect the ligaments and bursa as well around the joint. Occurs a short distance from the muscle's insertion, so where the tendon will sort of you'll have the muscular-tendinous junction at one end, and then you'll obviously have the muscle insertion right in the middle. Between those two areas is where you'll get a short distance of calcium. It always stays above the cortex of the bone, so it doesn't look as though it's sort of infiltrating into the cortex of the bone. Progresses to become a homogeneous, well-defined round or oval density within the joint. Most common in the shoulder, around the rotator cuff, and in the hip and cervical spine are the three most common areas. Here we have it on, this is obviously an x-ray of somebody's shoulder, and you've got, so where you've got the muscular tendinous junction just here, and then of course the rest of the tendon of the, this will be obviously supraspinatus muscle, basically all of the tendon leading down to the insertion of the muscle on the proximal humerus, is all of that is turned into very, very dense calcific tendinopathy. So as you can imagine, this will be very painful because ultimately obviously the muscle is going to be impaired in its function, so the shoulder is going to have impaired function, so this will cause most likely what will appear like a subacromial impingement syndrome in this particular patient. I've had a good few of these myself where you've got real obvious calcific tendinopathy occurring. Ultimately, in terms of management, trying to keep the joint moving and trying to keep it lovely and stable is about the best you're going to get, especially with manual therapies. Surgical intervention with this is going. I mean, it's not very commonly attacked by surgeons anymore. Because again the outcomes aren't all that great, so manual therapy is going to be the way to go really, with your keeping the patient pain free as best you can and trying to increase or trying to maintain stability of the joint to stop it from progressing and causing further complications around the rotator cuff and deltoid. Ultimately as well, somewhere in here you're going to have the long head of the biceps insertion as well. So again, it's just going to get in the way. It's going to cause big problems with these patients, especially when it's this severe. As I said, it can affect the bursa. Almost impossible to differential diagnose from a tendon off an X-ray in particular, because again, it's usually homogeneous density or round or oval, ovoid in its shape, and it's going to be somewhere around the bursal location. But as you can see, you're going to see on the next X-ray, to be perfectly honest, it could swing either way on that particular X-ray. If you were to write down it's going to be the tendon of the supraspinatus muscle, then I'm sure in your exam you'll get away with it. Most common is going to be subacromial bursa, subdeltoid, and then the ischial bursa. Subacromial bursa is obviously under the acromion, and the subdeltoid is going to be next to the greater tuberosity and the lateral aspect of the proximal humerus. And here we have a very large HADD of the subacromial bursa. This image in particular has got an enormous subluxation of the glenohumeral joint. To be honest, this is going to be pushing a full dislocation of the joint with massive involvement of the glenohumeral joint and the subacromial space, and that is all of this calcification just here is the subacromial bursa. So again, almost impossible to differentiate that from the supraspinatus tendon. So yeah, in your differentials list, guys, if you see this in your exam or you see this in the patient, write them both down, get some further imaging done, and see if this patient needs further investigations, because ultimately all the muscles, the delts, all of the muscles around here are going to atrophy with this, and you're going to have massive loss of function. So whether this patient needs a surgical intervention is going to be something that's worth discussing with their GP and a surgeon as well. So I'd refer this patient out for at least, he needs an orthopaedic surgeon's consultation and opinion just to be able to discuss the case with them and see what needs to be done. In the hip, most commonly seen in the femoral insertion of the glute max, is usually locally painful, so they will present with obviously hip pain. May simulate sciatica as well, so it can refer pain down the back of the leg. On the AP projection, It's seen inferior to the trochanteric region over the lateral portion of the femoral shaft. You can take a frog leg x-ray as well, where you'll see calcification of the outside of the cortex of the medial surface of the inferior to the lesser trochanter. And again, here we have a patient with, in this particular patient, we have it bilaterally. Okay, so spine looks good, sacroiliac joints look good, symphysis pubis looks good. There's no sign of any soft tissue involvement as well around the glutes and things like this. But when you look at the greater trochanter, you can see that this is going to be the insertion point for the glute max, and where you see that densities above the greater trochanter is where you'll find your culprit. So again, usually, I've had a good few of these myself. These patients will present with hip pain because ultimately the glute is going to be impaired in its function because you've got calcium being laid down in its tendon, which is going to make the tendon very stiff. So the muscle itself is not going to be a happy chappy. In the spine, in the cervical spine in particular, it's most commonly is associated with the muscle longus coeli calcification. So it's usually seen superior laterally to the aspect of C2 and C3 in the anterior region of those two vertebrae. Patient will present with a painfully stiff neck with muscle spasm and potentially dysphasia. The issue peaks at around 2 to 5 days of onset. It can resolve itself within 1 or 2 weeks. You'll get a nice amorphous calcification that can grow up to a good few centimeters, seen on the lateral film of the cervical spine, anterior and inferior to the tubercle of the atlas, within the retropharyngeal soft tissue space. You can also see an increase in the retropharyngeal space above the 7mm cutoff point, so it will simulate soft tissue swelling. Usually resolves to normal with no permanent sequela as well. So just to review your anatomy, here's the longus coeli muscles, anterior aspect of C2 and C3 in particular, and here it is on a lateral projection of an x-ray. So here's obviously C1, you've got the dens, the body of C2, here is the back of the patient's jaw, and here is the longus coeli muscle calcification given away by the arrows. Here's another one as well, and we've also got some calcification of obviously the anterior longitudinal ligament most likely, but here is the longus coeli calcification just there, just posterior to the patient's jaw. So these do really stand out like a sore thumb, in particular in the cervical spine. Here we have calcification of the annular fibres as well. So this is the intervertebral disc between C2 and C3. You know, this very large calcific body that's occurred just here as well. Here it is in the PEDS case, where again we've got calcification in the intervertebral disc of C3 and C4. This is an immature skeleton as well. You've got very, very, very short and long looking vertebral bodies. Here it is in the lumbar spine, again in the PEDS case. It's an immature spine, and we've got HADD deposits within the intervertebral discs. Here we've got it on this is an AP thoracic spine, and it's spread out amongst basically all of the thoracic vertebrae. So this one in particular is going to be quite idiopathic in its nature. We don't really know what's causing this to occur, but it's spread out throughout the thoracic spine. And again, here we have it again in the thoracic spine, in the intervertebral discs. Not affecting all of the layers in this particular patient, or all segments in this particular patient. This is going to be the diaphragm. Just here, this is probably going to be around sort of T8, T9 region. And then here we have obviously this is the iliolumbar ligament coming from the posterior aspect of the iliac crest over towards the transverse process of L5, and the whole ligament as It's very, very bright, very dense. This has got a lovely smooth border to it. It's quite clearly not a sort of pathological process in terms of like a cancerous lesion or anything like this. So we're not talking about a blastic lesion, blastic mets, anything like this. This is very smooth, very linear, spreading from, like I say, the transverse process of L5 over to the iliac crest. So that is your HADD within the iliolumbar ligament. So that's about it for today, guys. I hope you enjoyed this lecture. Feel free to obviously like and subscribe to the channel, so you'll get obviously updates of when I go, if we go live at all. If you guys want to have some live chats with me, I'm more than happy to do that. We can do that obviously via YouTube directly. So let me know if that's what you want to do, and I will be putting up more of these videos as you go through your studies. So yeah, enjoy the rest of your day, and I'll see you in the next one. Take care.